Good morning, everyone. My name is Dr. Sanjay Prabhu. I am a neuroradiologist at Boston Children's Hospital. And today I'll be discussing arterial spin labeled imaging in pediatric patients, a practical primer. The objectives of the talk are to quickly review the concept of tissue perfusion, take you through some current methods of measuring cerebral perfusion briefly, and specifically talk about arterial spin labeling and the different technical aspects of performing ASL, some special considerations in pediatrics and why it is such a nice technique to use in pediatric patients, and hopefully show you, convince you with some examples of ASL and pediatric neuroimaging that this is a very useful technique in practice. And finally, give you some technical notes to improve your own acquisitions of ASL. What's perfusion? Perfusion is the process of delivering blood to a capillary bed. In imaging, we equate perfusion with flow, but however, perfusion is not exactly equal to flow because flow is units of volume per time, which is ml per minute, whereas perfusion is basically flow per mass or units of volume per time per mass, which is ml plus per minute per gram. In the brain, we assume the mass is constant at about 1 gram per milliliter. So we use these terms of perfusion and flow interchangeably. The mean cerebral blood flow is about 60 cc per 100 gram per minute in adult humans. And it's about 1 milliliter per 100 mils per second, which is very, very small amount of flow. The CBF of gray matter is about 80 milliliter per 100 gram per minute. And CBF of white matter is about 20 milliliter per 100 gram per minute. What's the way to directly measure perfusion? There's a thought experiment. Let's say we inject some microspheres into the bloodstream. Some of these microspheres will get trapped in a capillary bed. Then we resect the tissue and look at the number of spheres within the given mass of tissue, which will yield measurement of flow to that volume. So basically looking at how many microspheres are getting trapped in the capillary bed. The relative perfusion to different brain regions is calculated by the differences in the microsphere concentration or the percentage of total number of spheres delivered. So this is exactly the same technique we use for any of our perfusion techniques. So different tracers can be used for cerebral perfusion, and they've been developed to get indirect measurement of cerebral perfusion because obviously you cannot inject microspheres and cut out tissue. So you can use either exogenous diffusible tracers like SPECT, PET, or xenon CT, or exogenous non-diffusible tracers, which is usually contrast like CT contrast perfusion, and dynamic susceptibility to contrast MRI, which we know about from other talks, hopefully in this meeting. But what I'll concentrate on here is endogenous tracers, which is where you use the blood in the bloodstream as the label. So there's no exogenous contrast being administered. And this is arterial spin labeled ASL or ASL technique. So the tracer here is endogenous water, and the ASL signal, which is the T1 longitudinal magnetization, is proportional to the local blood flow. There is no radiation in this technique. Acquisition is about a minute or 3 to 4 minutes, depending on the technique that we use. Spatial resolution about 2 millimeters, and you can cover the entire brain during the acquisition, and you don't need any contrast injections or any IVs. And the nice thing is you can repeat this as many times as you want during the same study or on the same day even, without actually worrying about radiation or contrast like you would do for DC with MRI or dynamic perfusion with CT. So how does ASL work? Think of this as an artery here, and you have the blood flowing through here, and the T1 magnetization of the flowing water, that's the water in the bloodstream, is inverted within the proximal vessel, and this generates a signal. So here you have magnetized this flowing water, it inverts the magnetization and generates a signal. And now the T1 signal lasts about 1 to 2 seconds in the flowing blood, depending on the field strength. So in that 1 to 2 seconds, the blood obviously now diffuses between the intravascular and the extravascular spaces of the capillary bed. The rapidly diffusing water molecules take longer because the extravascular space is much larger than intravascular space, and the labeled water molecules with the T1 magnetization accumulate within the extravascular space. Now, once that happens, and then the T1 signal now decays quicker than the transit time, because obviously this is taking much longer to come out rather than a couple of seconds where the T1 signal is going to be present. So signal is now trapped in the extravascular space, having dissipated by the time the water reaches the venous intravascular space. So at this point, when you measure it, there's some signal left behind here, but most of it is decayed. Now, by imaging while the T1 signal is accumulating within the extravascular space, the signal per voxel is proportional to the perfusion of the cerebral tissue. So it's very similar to the microsphere experiment we talked about earlier. So the accumulation of the T1 signal with the extravascular space is very similar to the microsphere model, but the SNR is very low because most of the labeled blood has lost its signal, and the signal strength of the labeled blood is now only 0.5% to 1.5% of the full tissue signal. And so you need to repeat this same acquisition multiple times and then subtract from the anatomic T1 signal and get you a summation of the signal readouts. So basically, here's the final accumulation of the signal in different parts of the tissue. And if you look at it, it's an image labeled tissue here. This is the control. And then basically you get the perfusion, which is a subtraction of the label minus the control. That's the perfusion derived from the labeled image versus the control image. In arterial spin labeling, the different labeling paradigms, you can do continuous ASL, pseudocontinuous ASL, which is called PCASL, pulsed ASL or PASL. Then there's 3D PASL or 3D pulsed ASL, velocity selective ASL, and there's also multi-delay ASL. And each paradigm consists of the labeling plane, so where you basically label the blood, which part of the artery or the vessel you label the blood, usually proximal. There's a readout plane distally, and then you have T1 labeled protons, which are the magnetized protons, and the unlabeled protons, which are going this way. So in these diagrams, this is what they mean, these colors mean. So now let's talk about this as the labeling plane here. So in continuous ASL, this is rarely used today, but you have a long application of gradients in RF pulses. It requires separate local transit times, and we label the water flowing perpendicular to the labeling plane. This is a higher SNR than other ASL methods. So here's the label, here's the magnetization, and you have a long application of pulses. The problem with this technique is it's high in SAR and cannot be used in pediatric patients, and also sensitive to magnetization transfer effects. And mostly it's not available in most clinical scanners. Next one to the pseudocontinuous ASL. This is the most commonly used technique nowadays, in addition to PASL. So you have a strain of short gradient pulses. So here's the labeling plane again, and that's the magnetization of the protons. And then after the short gradient, you just switch over, and then you have a readout plane here. It's capable of getting higher SNR with the lower SAR than CASL or continuous ASL, and it's susceptible to artifacts between the label and image. So you're useful in moya and neonates, although you still have to modify some of the delay in PCASL to make this work. It's difficult to optimally prescribe labeling plane, and this is something that we'll talk about in the technical section. And it's hard to reproduce reliably, but mostly works. It's a 4 to 5 minute acquisition and works pretty well. In pulsed ASL, you have a short RF pulse applied over a large volume. So here's a large volume, which is labeled here. And then here's a short RF pulse, which magnetizes these protons in the flowing blood. And then it's a preferred method in the older patients, takes 2 to 4 minutes for acquisition. And the newer volumetric 3D PASL on newer scanners, that actually is a much higher coverage and has a higher resolution in the same amount of time. So this is what we use in most of our clinical scanners now. The drawbacks are it's prone to problems with delay between the label and the scan. So if you, because there is a delay, if you have really fast flowing blood, for example, neonates, it doesn't work very well. And the labeling of systemic blood can alter cerebral data, especially in patients who have shunts. So here's again, that's the flowing blood after the magnetization going through the readout plane. The next technique is also selective ASL. It's a more newer technique. You selectively label all the blood flowing below a target velocity. So you take the whole volume and you check the velocity of the flowing blood using some initial preparation slices. And then from the labeled blood, you selectively read out any blood that is decelerated to the capillary velocities. This is not spatially selective, it's velocity selective. So it is really helpful in picking out flow, and it's less sensitive to the transit time errors. And so you can use it in patients with like moya or who have vasculopathy and revascularization procedures. And also it eliminates the erroneous intravascular signals. So here's a large volume, and you have labeled all the blood that has decelerated, and label all the blood in here, and then you read out the any blood that is selectively decelerated to capillary velocities. Special considerations: children. The brain water content in children is higher. And also the post-label delay correlates with the age, brain region, and disease process. And there's very fast flow in neonates and slow flow in other conditions of vasculopathy. So you have to keep this in mind when you try and do ASL in children. But one advantage is that the CBF increases with development. So there's a higher SNR in children compared to adults. So it's a useful technique to use in children as opposed to adults. Benefits of using ASL in children is the higher SNR, like I talked about. It's easily repeatable. You don't need any contrast or intravenous like injections or even needles. So this is also highly repeatable on the same day. The pitfalls are you can get systemic tagging, like I talked about. If you have really fast flow or really slow flow, then you have problems with the tagging. It's also prone to motion artifact, and children do move. So some motion corrections which can be applied, but still it's a motion sensitive technique. I should remember this when you are interpreting it. And it's lower SNR related to other perfusion techniques like DCE, and it's technically demanding, has to be done correctly, otherwise you get erroneous results. So let's talk about the abnormal patterns of perfusion on ASL. You can have hypoperfusion, hyperperfusion, or intravascular signal. And these are different examples which quickly talk about here. This is a patient with an infarct. You can see reduced diffusivity here. Shows this loss of flow and the showing focal vascular occlusion, and there's focal thrombus in the MCA on the SWI. And on the ASL, you can see that there's a region of decreased perfusion, which is larger than the diffusion abnormality that we had seen earlier, indicates a significant penumbra. And there's also corresponding increased intravascular signal here, suggesting delayed transit time. The patient had TPA administered on the table, and then the region of prior ischemia had reversed by the time the TPA infusion is completed, indicating hyperperfusion following revascularization. This is another patient, a 6-month-old female who was found unresponsive, suspected non-accidental injury. There's decreased diffusivity throughout the brain, showing and also evidence of herniation of the cerebellar tonsils, effaced basal cisterns, and scotedema. And on the ASL image, which is a 3D PASL technique, you can see a global cerebral perfusion, hypoperfusion, and all the labeled spin is within the skull base vessels here. So nothing is put into the brain. So brain death was determined clinically. And ASL is complementary in this situation. It's not a sole determinant of brain death, because an improper delay between the labeling and the imaging may falsely result in artifactually low perfusion signal. Something to remember if you're going to be using ASL in these kind of cases. Next patient is a hemiplegic migraine patient, a 2-year-old male who was working in his coloring book and found to neglect one half of his page. It was an interesting presentation. And on the conventional sequences, it was really hard to see any abnormality, but you can SWI, you can see increased veins here, suggesting subtly increased oxygen extraction. Perfusion was markedly decreased on the ASL throughout the left cerebral hemisphere, with sparing of the basal ganglia and thalami. As you can see here, this patient had hemiplegic migraine. Next patient is a patient with tuberous sclerosis who had multiple tubers, and on the ASL, you can see areas of hypoperfusion. This is a patient who is interictal. The next patient here is a patient with profound hypoxic injury, and you see that there are areas of abnormal signal in the brainstem and the basal ganglia, and the diffusion restriction here in the same areas suggestive of profound hypoxic injury. On the ASL, you see there's a reperfusion injury. So although there's a diffusion restriction and hypoxia, on the ASL, you see hyperperfusion, which is a reperfusion pattern of injury to these same structures. This is a 3D PASL again, and noted that the whole brain coverage, thinner section, thinner slices, and higher resolution of these images shows you nice detail of the anatomical structures. There's another patient with profound hypoxic injury. Here you have very subtle diffusion restriction and flare abnormality in the thalami. But on the ASL, you can see much more extensive perfusion, hyperperfusion, suggesting this reperfusion pattern of injury here. And when you follow this patient up, those areas which were initially abnormal, like almost normal or even subtly abnormal here on the diffusion and flare, were infarcted on follow-up 11 days later. So the ASL picked this up much earlier than the conventional imaging. The next patient is a patient with infection. It's a patient with encephalitis, HSV encephalitis, and this is area of decreased diffusivity and increased enhancement, which you can see increased perfusion here on the ASL image focally in that region, consistent with active inflammation from the infective process. The next patient is a patient with infection. It's another patient who had meningoencephalitis unknown etiology. Here, the conventional imaging shows very like flare hyperintensity and possibly very subtle to almost no contrast enhancement. And diffusion is subtly decreased. But on the ASL, you can see really florid hyperperfusion in the areas of inflammation. So again, ASL is a sensitive technique which can trump even diffusion in some scenarios. There's a patient periictal, a patient with epilepsy, a patient with epilepticus, and the MRI was performed soon after seizure activity had been controlled. You can see the right cerebral cortex here is widely decreased in diffusivity on ADC map here, and there's hyperperfusion of the cerebral cortex that supports the periictal state. And just like PET scans, ASL can demonstrate hyperperfusion in the periictal period and hypoperfusion in the interictal period. The next patient was a patient with Alpers syndrome. Here, I saw this patient with seizures and was described clinically as epilepsy partialis continua, and he had high occipital rhythmic high amplitude delta with superimposed spikes or RAD, hallmark pattern of Alpers syndrome. The MRI was negative except for asymmetric hyperperfusion in the occipital lobe, corresponding to the EEG abnormalities, also in the thalama on the same side. Well, that's definitely diagnostic. In this case, ASL corroborated a clinical diagnosis when other protein sequences were called normal. The next patient is a patient with PRES, and you can see T2 prolongation in multiple areas on the conventional imaging, and you can see elevated ADC values. And there's on ASL, you see areas of multiple areas of hyperperfusion in the areas of vasogenic edema. This is a classic trace of PRES. And a 3-month follow-up, you can see that these abnormalities in the initial imaging had gone away, and the ASL had actually become normal as well. There's a patient with MELAS with right-sided sensory deficits, and you can see an area of flare hyperintensity and T2 hyperintensity in the subcortical white matter with different vascular distributions. And then you have these areas of hyperperfusion on ASL. Studies have shown that areas of hyperperfusion in MELAS correspond to areas at risk, whereas the chronic subcortical abnormalities shift towards hypoperfusion. So the more active areas which will be at risk are hyperperfused in MELAS patients, like in this patient here. This is a patient with medulloblastoma, where you can see the tumor shows very high perfusion, just like in endoperfusion techniques. Preliminary studies of pediatric tumors have suggested a correlation of hyperperfusion with higher grade. There's a patient with moya here, where you can see a decreased flow rate and enhancement in the MCA on the left side. And here on the perfusion, you see intravascular enhancement in the left MCA distribution, indicating delayed transit times through the synangiosis, which is the vascularization procedure to be used in these patients. This patient is a patient with sickle cell crisis, and here you can see DWI showing scattered areas of infarction in the distal vessels, and the perfusion is decreased in the areas of infarction. And perfusion is decreased in the areas of infarction. There's also a regionally increased intravascular signal, which indicates delayed transit times, most likely from narrowing of the proximal vessels. Quick technical notes here. PCASL is the best labeling efficiency. It labels the most blood per TR, and so produces the best CBF maps. And the labeling plane of PCASL should always be perpendicular to the major arteries. For example, if head's placed like this, your labeling plane should not be like that. It should be perpendicular to it. So it should be like that. And this is a major source of error in ASL acquisition. The other thing is, remember, is the post-labeling delay is about 2,000 milliseconds in neonates, 1,500 milliseconds in children. And also you can use multi-delay techniques for more accurate quantification. And between 4 and 7 post-labeling delays available for a 4 to 5 minute acquisition, most of the newer scanners. It's useful in slow flow states like stroke, hypoxemic injury, and vasculopathies like moyamoya. So this is one of the newer techniques that can be used. So in conclusion, we have talked about multiple methods to measure perfusion, and of this ASL has a very important role in patients with pediatric patients, because you have high SNR, no analgesic radiation, it's endogenous tracer, readily repeatable, and we use it in our population in patients who all neonates, patients with stroke and moyamoya, mitochondrial disease, epilepsy patients undergoing phase 1 evaluation for focal seizures, also patients with seizures and migraine from the ED, patients with PRES and encephalitis. Perfusion abnormality alterations can precede abnormalities in routine sequences and thereby allow early detection. So ASL is something that you should consider in your clinical patients as well. Thank you very much for the opportunity to speak to you today.